Assalamu alaikum, my name is Ali Muhammad Abbas. This is my graduation project about the prevalence of torus palatinus in patients attending prosthetic clinic or students group in University of Baghdad College of Dentistry, supervised by Assistant Lecturer Dr. Mustafa Shakir Mahmoud. In this project, we study the torus palatinus with their prevalence and their effect on edentulous patients, and finally, we study their treatment. The introduction. The tori meaning the stand out or lamp in Latin. They are exostoses that's formed by a dense cortical and limited amount of bone marrow. They are covered with a thin and poorly vascularized mucosa. They are usually located in the longitudinal ridge of the half palatine. The torus palatinus varies in their shapes and size, and this is directly related to the retention and stability of the denture. The size of torus palatinus. The growth of tori is gradual and being greater in second or third decade of life. Hogan in 1992 and Egan and Native in 1994 classified the growth in terms of small, medium, and large. Less than 2 mm was small, and 2 to 4 mm was the medium, and more than the 4 mm was a large. According to the study of Hogan in 1992, the majority of torus palatinus was small, with 69.85% was small. The study of Jane Kintoving conclude that the small tori were more common than the large tori. Types of torus palatinus. Tori are sometimes classified into their morphologic appearance: flat, spindle, nodular, and lobular. The flat has a broad base and slightly convex with smooth surface. It extends from both sides of midline raphe. Spindle has a midline ridge along the palatal raphe, and nodula arise from multiple protuberance. Each has individual base. Lobula has lobulated mass but arise from a single base. The radiographic feature. The torus palatinus does not appear on routine dental radiograph. Rarely it may be seen as a radiopacity on periapical films if the film placed behind the torus when the radiograph is taken, as we see in this picture. The histopathologic feature. Microscopic examination of torus show a mass of dense lamellar cortical bone. The inner zone of trabecular bone may be seen. As we see in this picture, the trabecular bone with osteoblastic rim at the base of the biopsy. The etiology of torus palatinus. The exact cause of appearance the tori is not clear at the moment. The most widely acceptable theory was a genetic. Another cause is a superficial injury or its occurrence as a functional response in individual with well-developed joint muscle, or at the patients with abraded teeth due to occlusion. As another possible cause, they mention the eating habit, the state of vitamins deficiency or supplements rich in calcium, and also diet. Now we will talk about the prevalence of torus palatinus. The prevalence of torus palatinus is very important. There are a lot of studies in the world show the prevalence of torus palatinus. For example, according to the study of Al-Bayati in 2001, 12.3 in Trinidad and Tobago and West India has a torus palatinus. Very close to Al-Bayati, Browse in 2004 found a 14.6 in Ghanaian community has a torus palatinus. In Jane Kitoving in 2000 showed their prevalence of torus palatinus was 26.9 in Thai population. Hogan in 1992 found 9.2% in 5,000 Norwegian population had a torus palatinus. On other hand, Shaw and Tan in 1884 show that the 48% of Chinese patients had a maxillary tori. Al-Quran and Yawari in 2006 reported that the prevalence of tori in children was a 13.9%. The frequency of torus palatinus among the Anatolian population was at 62.8%. And now the age. It's not easy to compare the range of ages provided in the studies that I have analyzed, since in many cases they are not standardized and each author gives a different references. For example, according to the study of Browse in 2004, the average age of tori was at 34, and according to the Al-Bayati in 2001, the average age was 13.7. Now let's talk about the gender. It's most frequent for torus palatinus to appear in female than in male. That's believed there may be a dominant type linked to X chromosome. In all studies, there is presence of TB high in female than in males. For example, Jane Kitoving in 2000 found the ratio female to male was 5 to 1. Another study by Browse in 2004 found 2 and 2 times more in female than males. Now the ethnic group. The appearance of tori are more common in certain ethnic groups and countries such as Eskimos, Japanese, and United States. Other research found the prevalence is generally high in Mongolians than the Caucasian in their studies. The diagnosis of torus. In most cases, the finding is usually incidental and observed during the clinical examination in dental office. This is because the torus palatinus is asymptomatic, and most of people who had torus palatinus don't aware about it. Sometimes the patient may present as a phonatory disturbance, limitation of masticatory mechanics, ulceration of mucosa, food deposits, prostatic instability, and some patients may experience cancer phobia. So for all, we can diagnose it by clinical examination. Now we will talk about the torus in denture. The principles of denture. There are three key principles factor in prescription and provision of successful complete denture. They are retention, stability, and support. The relationship between these factors is also important. Denture fit is also described in terms of retention and stability. Retentive complete denture are reliant on the interplay between the factor retention and stability. Now we talk about the management of the tori. The presence of the tori or other bony exostosis must be detected, and their presence in relation to the framework design must be evaluated. Failure to palpate the tissue over the median palatal raphe to ascertain the difference in its displaceability as compared with the displaceability of the soft tissue covering the residual ridge can lead to a rocking, unstable, uncomfortable denture and to dissatisfied patient. Adequate relief to the palatal major connector must be planned, and the amount of the relief is directly proportional to the different displaceability of the tissue covering the midline of the palate and the tissue covering the residual ridge. A maxillary torus provides the challenge where restoring a dentulous arch. Tori tend to have a very thin mucosa and can be intolerant of the normal pressure from the denture base. The tori tend to have a large intercant and at times extend to the junction with the soft palate. preventing the creation of good palatal cell. A new technique that's known as a triple lamination technique are used. This is involve a combination of three materials. This helps us to fabricate the denture base that utilize the retentive aspects of the torus. The three materials I used is the thermoplastic flake is to provide a measure of flexibility allowing the denture to sit over the torus. The resilient liner provide a cushion to diffuse the occlusion load while the rigid acrylic provide a support for denture teeth. By using this approach, a very retentive denture was fabricated using the maxillary torus as a key element in anchoring the prosthesis. The major connector that used with the presence of the torus palatinus, the combination of the anterior and posterior palatal strap type connector. But if we have a large inoperable torus palatinus, we should use a U-shaped connector, as you see in this figure. On your left the U-shape and on your right the combination of anterior and posterior palatal strap type connector. The removal of torus palatinus. The torus palatinus is not always necessary to remove. It's removed when it's problematic. It includes the edentulous patients if it extends to the vibrating line to preventing the posterior palatal cell of the denture and the posterior palatal cell of the fovea palatina. Another indication for removal is a traumatic torus, or if it's disturbance of speech. Another cause of removal if the patients who are cancer phobic. There are a different incision to remove the torus palatinus, but the most common type is a double Y incision because it prevents the injury from the nasopalatine and anterior palatine block. The incision is B of the total thickness. In this picture we have a double Y incision technique for remove the torus palatinus. The post-operative care. The patient must inform that the sign and symptom that may occur post-operatively, such as edema, hematoma, and mild pain. Post-operative medication can consist of antibiotic, analgesic, anti-inflammatory medication. Thank you for listening, and I'm ready for any question.